Over the years that we've held the ABSARD meetings, we've had repeated feedback that one of the most fun and enjoyable and informative parts of the meeting is a chance to talk to experts about how they handle complex situations, cases that are not written about in the literature or for which there are no real great evidence-based trials. Because as you all know, evidence-based trials tend to be very selective, and we can't be selective in clinical practice. We have to see whoever comes to see us and sort things out. So let me just introduce our panel to be sure that if you haven't already met them. So immediately to my left is Dr. David Goodman from Hopkins, a world-renowned expert in adult ADHD. We've got Dr. Mary Salanto, who's been moving around New York to different programs, is now at NYU, and who is a world expert in adult cognitive behavioral therapy. Next to her, needing no introductions, Dr. Len Adler, also from NYU, and Dr. Richard Gallagher. We got an NYU heavy panel here. We've got Dr. Jim McCracken from UCLA and myself, and I guess I sort of switch hit because I see kids and adolescents and adults. And I'm Tony Rostain from Penn.
And I'm in private practice, see ADHD as part of a general private practice. The question is on medications. I'm in a relatively underserved area. PCPs are often talking with me on the phone or have referred individuals that have slushed through the system. Again, I only deal with adults that have never been diagnosed with ADHD. Developed a model with Russell Merkley and Kevin Murphy that I've used in my practice for years. So once they're diagnosed, the question is first-line medication. I wondered if you could run through an update in my practice. Seems like many more people are on the amphetamines than on the methylphenidate. And I just wondered if you could kind of update and also talk a bit about Vyvanse, because that's a favorite in my area now. It seems to go in smoother, go out smoother, a longer span. And if PCPs are talking with you, I'm desperate, I don't know about this. What have you found in your practice other physicians in our area are prescribing?
Did you bring your slide?
What do I say?
First of all, Nancy, I salute you for that you've taken this patient population on, that you probably didn't get enough training when you were in residency, but now you're in the front lines, and that you've got relationships with the PCPs, because we think you're in a critical position to have an impact on the lives of the patients we're here to serve.
Exactly, and these are uncomplicated folks.
I know, I understand, but
that are definitely not bipolar.
Right.
The comorbidities are just anxiety, mainly dysthymia.
Right, garden variety, but never been diagnosed before.
And
okay.
they've never been on a stimulant before.
Right, go ahead. Let's see, what are your first lines here?
Okay, so there is no one first-line medication. Let's start with that, okay?
Right, but where do you go in your
okay,
practice?
so the first thing we start with is a diagnosis. So diagnosis
well, that's
has
already
to drive
done.
treatment.
We're assuming
so that's
been
done. But
by me, because they referred.
And I understand that, but I want to echo that to the audience. The next step is trying to understand the decision between a stimulant and a non-stimulant, okay? And there's no easy answer there. I'm going to give you, and there's no treatment algorithm, and there are no treatment guidelines for adults, so I'll give you my personal opinion, okay? When there's no data, we talk about our opinions.
There's no guidelines in the U.S.
There's no guidelines in the U.S. That's correct. Thanks, David.
Well, people do have an expectation, usually by the time I have them do the research, that they'd rather have a stimulant. So going with something like Strattera, we've talked about that, or their PCP have educated them, they're less interested. They like a quicker fix. Or
I know they like quicker fix, but I don't always do what they want. Now, I tend to be a bit of a hard ass there. I tend to look at the low-hanging fruit first. If there is active substance use or profound tics, okay, they go over to atomoxetine, rule 1, okay? Then we tend to take a look at what they've taken before, or if there's someone in the family that's been diagnosed with ADHD or treated with something. That may help you sift through the sands and pick apart what you might want to give. And symptom severity can be helpful, because we know there is science here that the effect size of the non-stimulants will be about half of what we get from the stimulants. And if you pick a patient with very severe ADHD and give them a non-stimulant first line, that may influence things. Now, that all being said, if you're going to use a stimulant, the 4 approved stimulants in ADHD are all sustained release. I think that for adults, the first-line therapy should be a sustained release medication because we're trying to treat them throughout the day. And there are generic versions available of oros methylphenidate and mixed amphetamine salts, XR, which is Adderall XR.
And now Focalin.
And Focalin XR is now just come off and is now available generically, so it's 3 actually. And Vyvanse is the one approved prodrug that's not available generically. So then you have to make a decision. The next pass, once you decide to use a psychostimulant, is are you going to use a methylphenidate or an amphetamine-based compound? And there's no right or wrong reason here. And we're dealing with the art form of prescribing. If you're using oros methylphenidate, the FDA has put out a warning on the Mallinckrodt version of the compound because it's a different release mechanism. I do talk with patients about that. I think that's important. If you're choosing to use an amphetamine and you want a longer, smoother acting amphetamine, the Vyvanse, there is data, will have clinical effects with less rebound. We presented on this, probably out to about 13 hours. Not everyone gets 13 hours. But those sorts of things are the things you need to keep in mind, and there's no right answer.
Right. We have a problem in Pennsylvania with insurers so that oftentimes the PCPs don't want the hassle of documenting the failures before they get on to the Vyvanse. And that's if it's the insurer is paying for the medication.
Sure. So that means they've got to fail something else, which means they're often getting oros methylphenidate or mixed amphetamine salts XR. I don't think the coverage has improved on Focalin XR quite yet, but that'll catch up as the pricing comes through. The other thing to keep in mind is if you have a patient who comes in demanding short-acting Adderall and will only take short-acting Adderall.
No, this isn't the case at all. These are usually people that genuinely want help.
I know they're solid.
This is salt of the earth, middle Pennsylvania.
They're from Happy Valley.
No, I understand. But on the other hand, this is for the audience, if that happens, okay, bells, whistles, alarms should go off, okay, because the data does support the greater use of the greater risk of misuse and diversion of short-acting mixed amphetamine salts, and you've got a very high bar to show to me why you won't take a sustained release medication if you haven't taken it before, if you have a condition that affects you throughout the day. And
Len, let's get others jumping in. Go ahead, Jim.
I was just going to add a short point that I've been impressed with the more and more adults that I treat of the number that do prefer short-acting stimulants simply because their schedules are so highly variable. The sort of prototype would be the college student who, some days doesn't have a class until 2 in the afternoon. Their daily schedule is quite variable. So I usually go in, or I have been going in with this mindset of sustained release is the best, but my patients don't always agree with me on that.
So let me also weigh in on some of these issues, and Len will be the first one to correct if I make a misstep. Of all of the long-acting medications, the only one that has a duration trial in adults is Vyvanse, out to 13 or 14 hours. So although Adderall XR, Concerta, and Focalin XR are approved in adults, they don't have duration over the course of a day studies. The Mallinckrodt preparation of oros methylphenidate is problematic, and the way you find out in the state of Maryland, CVS and Target have different pharmaceutical distributors than Walgreens. So you have to find out. And this is important because if you write a prescription for Concerta and they get it generic and they come back and say Concerta doesn't work, it doesn't necessarily mean Concerta doesn't work. It means that the generic they got didn't work. And that might be a misstep in your pharmacologic algorithm. So you want to think about that. The other thing that I do, and this is completely off-label, everybody understand that? What I'm about to say is completely off-label. I resist writing short-actings, and I resist writing boosters. So people will say, well, the long-acting only gets me out to 4 or 5 o'clock. What do you do? In child psychiatry, they say you take a booster and get another 4 hours. I don't do that. I do long-acting BID, and my formula is X milligrams in the morning and half X milligrams at 1 to 2 o'clock. That carries them out to about 8, 9 o'clock, and generally they do not have insomnia. And that way there's fewer short-actings. I know Lynn's going to say something. There's fewer short-acting medications in the medicine cabinet at home. Now, talking about the economics, I appreciate what's going on. We're all getting pushback on that. If you're prescribing short-acting, just make sure that you're monitoring the number of pills the person is getting. There's an explanation as to why the pills are lost. And you're keeping track. I do have patients taking short-acting. They take it 4 times a day. They've been taking it 4 times a day for 5 or 6 years. They lose 1 or 2 prescriptions a year. They're very compliant. So there has to be some level of trust. If you can push back on the insurance companies, because none of the short-actings have an FDA approval for adults, I get on the phone and I say, I understand our phone conversation is being recorded, right, by your company? And they say yes. And I say, okay, well, I'm recording the conversation as well. So are you suggesting that your company is recommending a non-FDA approved product for your prescriber and my patient? And when you put them on a recording, they don't answer that question. So that's one way that I kind of strong-arm them. This is completely off-label. It's just in my clinical practice. I don't know if it'll work in Pennsylvania.
I don't want to give the impression that we don't ever use short-acting stimulants. That's not the case. But I always start, we were talking about starting.
Yeah.
I start with a sustained release. I think David is a very sophisticated psychopharmacologist. And most people will start with a booster dose of a short-acting in the afternoon rather than giving a sustained release preparation in general. So I didn't want to leave the impression that that you can only give 2 doses of a sustained release. I think that's done less commonly. It's a very sophisticated maneuver by a knowledgeable prescriber. In our hands, probably about 40% of the adults need a booster dose in the afternoon. It's not uncommon, but we don't start there. We have a discussion about duration and what the expectation is for how long the medicine will work, and preparing them that it may wear off. And they may notice the wear-off more intensely as the dose gets higher, and then we deal with the afternoons.
So that sort of,
Okay.
but what it does say is that when we introduce the notion of a stimulant, we not only talk about the difference between how methylphenidate works from amphetamines, and we say methylphenidate has a more simple mechanism of action. Amphetamines a stronger mechanism of action, but we don't know which one preferentially you will respond to. And the second thing we talk about is the different preparations and the way, you know that most people, when you give them an Adderall XR and you say to them, how you doing, they don't realize that Adderall XR is not a continuous release. And we have to explain, it's a biphasic. It's like taking 2 short-actings. And they don't realize that. Because because whatever, they think it's extended release. So you have to really explain what the mechanism is of the delivery system you're giving, and tell them that the generic Oros is not Oros at all. It's not an Oros delivery system. So you have to be clear and get them to read up on it. And that'll always get them at least to be aware of why they might or might not need a booster dose, et cetera. Okay, let's move on. Oh, Mary, I'm sorry, Mary.
That's okay. I just had a comment on the regularity of usage. I know there are a lot of adults who seem to prefer to take it on a PRN basis. Yeah. They think that that's okay. And I try to tell them, when do you not need to utilize your full attention? I mean, it's not just when you have it for college students, not just when you have a test, not just when you go to a lecture. I mean, you need to be able to study on a regular basis. You need to have it for then. And, if the issue, as I think in many cases, is that they're concerned about developing tolerance or side effects, I try to disabuse them of that risk or the concern that it's going to have negative long-term effects on their health, which I think sometimes motivates that. Also, I'm trying to get them on a regular sleep-wake schedule so that, the stimulants can be utilized to facilitate that. And this being on a regular schedule can facilitate the stimulant use.
Okay, I just want to also point out your question. One of the things, there's a study that was, I think it's AU.
Bring the mic closer, Rick, because we want to hear you, or raise it up or something. Okay.
Yeah, AUIL, maybe 2 L's, ER. We looked at food and what blood levels were with regard to mixed amphetamine salts, extended release versus methylphenidate oros. And methylphenidate wouldn't change, but there was about a 50% drop if the kid or adult took their mixed amphetamine salts that were extended release with like cereal, milk, some fatty breakfast, and a lot of the variability with my patients, I always ask them, what have you been eating? Take it on an empty stomach, and a lot of that late afternoon dosing I don't need because of that. The question I had was really more about...
So you want to just clarify the recommendation around breakfast and eating and taking the pills?
Yeah, you basically want to... No, you don't want to take it with food. You want to take it roughly about an hour or so before you eat, or at least 45 minutes, and it shouldn't be a high-fat meal, etc. And you can pull up, but it's very interesting, and a lot of the variability you see in kids as well as adults, that's what it's due to, in my experience. Levels are literally cut in half, and that's a pretty big difference. So the real question I was going to ask, though, had to do with substance use disorders. And so many of these patients do have comorbidities. A lot of us obviously check prescription drug management programs, see where they're feeling, et cetera, how many other providers they're doing. What do you do if they've already failed, say, the tamoxifen, Lynn? What do you put them on if they have a history of substance use disorder and have ADHD? And it's open to everybody.
So they failed amoxicillin, and I guess the question is, and first question is the substance abuse active or remote?
Yeah, and we could do it both ways.
Oh, you're making it easy for me, huh?
Where's Francis live in?
Okay, so, you know, if the substance abuse is remote, you have more options. I think it depends how remote. It depends whether they need to be engaged in substance abuse therapy at that point, but I think when there's substance abuse, longer, smoother first, okay? So, because I think it's a people and places and things sort of phenomenon, and if you peak and trough your drug, it's going to feel more like something that you may have taken previously that was abused. So therefore, personally, if I'm going to use a stimulant, it will be oros methylphenidate or lisdexamphetamine, because I think they have the smoother release. You have the ascending curve and oros methylphenidate, and you're a prodrug with Vyvanse, and we showed some data on our poster on the PK profile of the amphetamine and the prodrug with Vyvanse. So, but if there's active substance use, and I'll quote Tim Willens here, you can't treat the ADHD through the substance use and the substance use through the ADHD. Both must be engaged and under the therapeutic umbrella, or else you won't succeed.
Okay. The only other thing that's making it hard all over now is the marijuana law is changing all over in the potency, but that's probably beyond the time you have.
So wait, I actually would just suggest that next year we do have a symposium on that, on marijuana and the marijuana laws and marijuana and ADHD, and what do we know and what don't we know. And maybe we can invite Paula Riggs or something.
It's one of the most common substances that are used, and the best anecdote I can give you is I was interviewing for residency applicants. We had someone from Colorado come in, and I said, what are you seeing in the emergency room? And she said, oh my God. The number of cases of psychosis coming in have just climbed through the roof, and it's from the edibles actually. But the marijuana is much more potent, and in the edibles there's no control on the amount of hash oil they can put into the edible, so they're supercharged.
Yeah, like Lynn and I were talking the other day, but when I was a medical student it was 0.2 to 0.7% THC. And now the national average is 10 to 12%, and a lot of this stuff's 25, 30, 40% THC. So it's really a challenge.
Thanks, Rick. Come up and introduce yourself.
Hi, I'm Beverly Fong. I work at the GW Student Health Center. I just had a question about how you guys personally treated sleep disorders after you've screened out any other, like insomnia symptoms, after you screened out like sleep disorders and, gave advice about sleep. Sleep hygiene and try to regulate those things. Just
how to manage sleep in like college age and others. Okay.
Or just in general.
Good.
Insomnia.
So one is to make the distinction, is the insomnia secondary to the medication, or whether the insomnia is secondary to ADHD, or secondary to a factor, situational or whatever. But just assuming that they have a primary sleep disorder they have a sleep disorder secondary to ADHD. In order of what I do, melatonin, Benadryl, and then use alpha agents, trazodone, doxepin, Seroquel. I really don't like using the atypicals because of the metabolic profile, but 25, 50 milligrams of Seroquel in that order. Do you have other suggestions?
Sleep hygiene, turn off the lights, set an alarm to remind yourself to go to bed. Often it's that they can fall asleep and are just so engaged or active that they choose not to. And I think that's something which I think Mary and Rich probably can comment on. That's a major factor. I mean, it's simple intervention, but just remembering to go to bed. If you have to medicate, then melatonin first and then move up to the higher level agents, trying to save the atypicals unless you really have to use them.
Do you guys use
I recommend life-threatening exercise.
And yoga.
How many injuries do you get from yoga, though? We haven't looked at that.
I could tell you stories. The other thing I was really going to mention as a question, I've come across some descriptions in the literature of using large single doses of gabapentin to treat insomnia. Do you all
I've seen a couple of patients.
Have you guys had much success with Romeltion or Rosarum?
Go ahead.
Yeah, some. I mean, I've had some success with that. If they're going to, one thing about the melatonin though is that I'm very clear. Well, I'm clear. It's a salient fact that you have to have them get the melatonin in an opaque container because melatonin is light sensitive.
Teenagers.
So, I've had patients that have failed melatonin, and I asked, was it in a clear container, and they said, yeah, and I've had them go out and get it in an opaque container, and it works. So it's a light-sensitive hormone, so it kind of makes sense.
The last thing I'll mention is that we have there's been clinical trials of CBT for insomnia. It's called CBTI. It's incredibly effective. Yeah, and it has got a science to it based on circadian rhythms. And I would say that if you have an intractable insomnia situation, especially it works even with ADHD patients, they have to be willing, though, to change the way they approach everything about sleep. It's more than just sleep hygiene. This is a very well thought through methodology, and it takes about 6 to 8 weeks to really pull it off, but it works.
And the steps behind it are not, they're hard to be able to get consistency, but they're not that complicated. The other part, being a behaviorist, would be I'd want to be able to functionally make sure that you understand the nature of the environment. Yeah. Because a lot of times in a college situation, it's because the dormitory is really not getting to sleep at the right time, and the roommate has a very different schedule. But it is pretty important to be able to see about making sure that the students are following the same general routine, even if they have Tuesday and Thursday classes that are at 2, and Monday, Wednesday, and Friday classes that are at 9, to try to get them onto a same pattern. But those are some of the steps that are included in the CBTI.
Okay, great, thank you.
Okay, and our final question for the conference.
Yes, hi, my name is Alex Storch. I'm a fourth-year resident at Maimonides in Brooklyn. And
welcome.
Thank you.
Glad you could make it.
Thank you. I inherited a patient that is on Modafinil. She's taking for ADHD, and her previous provider was giving this to her. It's become a discussion between me and the attending as to whether or not she should stay on it. My understanding is it's not FDA approved, but any thoughts on use of Modafinil?
Thoughts about Modafinil? Great question.
Well, was it prescribed for sleep apnea?
No, actually it was prescribed for ADHD.
And had she gone through a sequence of the more traditional agents?
She had a history of substance use, and so they didn't want to give her, methylphenidate or Adderall.
Right. Is she better?
The patient has also a diagnosis of bipolar disorder, PTSD,
This is a great resident case, yeah.
borderline personality disorder.
We would count it. Good case.
So, it's a pretty complicated case.
What dose?
Of Provigil?
Yeah.
100.
100 a day.
In the morning, she
Okay,
takes 100.
so here's I'll give you the randomized clinical trial answer and then hopefully try to give you some guidance because you've got a very complicated patient. Modafinil is one of the few medications where there is a difference in the clinical trial results between children and adults. Whereas the child study was positive, the adult study was not. And the adult study, thankfully, has been published, and there is efficacy within the adult data. But there's issues in terms of how high you have to go for adults and tolerability once you take it up fairly high. And the reason it's not on the market for ADHD is that there was a serious adverse event with rash in the child study, which held up its approval, is my understanding.
Just to give you some idea of the dose range on the Modafinil adult trial, it went up to 525 milligrams a day.
Right. So 100 is a very low dose. Most patients when I've given it, it's generally in someone who has not responded to anything else. And sometimes when there's a history of substance use, I think that it's a lower scheduled compound, and I think it's sometimes used that way. I often find I have to follow David's regimen on this one and dose it BID with a smaller dose later in the day because the attention boosting capacity is not adequate to get through the full day. But this is a very complicated case that you've got where you've got to be sure that the bipolarity is kind of stabilized because that is probably the most difficult comorbidity combination that we have in terms of treatment. Throwing PTSD into the cocktail makes it even more complicated. So this is also the type of patient that you really want in psychotherapy in addition to psychopharmacologic management.
I have a question for you. How's her sleep pattern?
Always complaining of
Always
sleep.
complaining. And does she complain about nightmares?
I think at times has, but not consistently.
Okay, because so we were talking about hypnotics at night, and it's not a hypnotic, but you can look up prazosin. Here's a good exercise for a resident. Okay. Look up prazosin in PTSD, nightmares. Yeah. There's some really good literature on there, and it'll just add another tool to your toolbox.
Yeah, I was thinking prazosin as well.
Thank you.
Sure. Okay, everybody, thanks for your attention, and please tell your friends about this organization, fill out the forms, and hope to see you next year at our meeting. Take care.